do you then give, that's actually an interesting perspective here too. So about this rituximab, the cladribine plus rituximab issues, then MD Anderson or Farhad, do you give mostly almost all patients cladribine plus rituximab or any other downside that you see or patients that you probably wouldn't consider adding rituximab?
So we have continued the study. I mean, this is actually probably the longest lasting study in our department and probably in our institution. It was open in 2003 and still
Oh, wow.
active. So we still enrolled to the study. And for that reason, we still use it sequentially. And again, because we've had such good results, we didn't feel the absolute need to do it concomitantly. Now, I would tell you more recently, in the last couple of years, because the NCCN guidelines doesn't even mention clinical trial as an option for frontline therapy of hairy cell leukemia, specifically says cladribine or pentostatin. We've had some problems with insurance companies approving it, so we've treated some patients with cladribine alone. And actually, more recently, I have treated a couple of patients just with cladribine alone because they didn't want, because of the COVID situation, they didn't want to get the additional immunosuppression, and they weren't that keen on getting vemurafenib for whatever reason. Yes, we are still using that strategy, and I can tell you the responses continue to be durable many years later.
The one thing actually I wanted to also bring up is that, and we're talking about the goals of a therapy for these patients, which obviously the first goal is the reversal of their cytopenia. I think some of the questions that do come up, and we do see occasionally after they get therapy and let's say they get a bone marrow biopsy either 4 months. Well, I guess we can talk about, does everybody need a bone marrow biopsy after getting this type of a therapy if they have a normal blood count? And then the second is that when they do get it, I see that even despite the fact their blood count is normal, because of the persistent presence of a hairy cell leukemia, some of these patients may end up getting recommendation for another lines of therapy, which may be important kind of the topic to just to clarify here. So maybe Dr. Saban or anybody actually can kind of comment on that need for bone marrow biopsy and what to do with the bone marrow biopsy information.
Actually, in my practice, I don't do a post-treatment bone marrow, as long as their blood counts have normalized. If there's ongoing cytopenias, I may elect to defer that bone marrow, but I don't do it routinely. I don't treat to minimal residual disease. If I'm going to use the rituximab, I'm going to use it upfront, and I'll wait and see. But I don't treat people based on minimal residual disease. Just to go back to Dr. Ravandi, I tend to use the combination in younger patients, in older patients. I'm not sure they need to be disease-free for longer periods of time because their chances are they're going to die of something else. So I don't routinely do a post-treatment bone marrow. Dr. Kudra had mentioned that you can do a bone marrow at 4 months. I have data that patients can be positive at 3 months, negative at 6 months, positive at 6 months, negative by 9 months, positive at 9 months, and gone at 12 months. So it's very important when you do your minimal residual disease, 6 months may actually not be long enough. I was the fellow doing all the bone marrows on all these patients. And what struck me was that we didn't know exactly when to do them, that some people would only convert at 1 year. So I'm not quite sure what it means. And Dr. Ravandi's study, I don't think required a bone marrow at 4 weeks. You just did it. So I think if you're going to use rituximab, just do it. And I'm not sure a follow-up bone marrow is going to provide all that much information outside of a clinical research study. But I noticed consensus reviews and everything else always call for a post-treatment marrow, but I'm not sure what you do with that information except upset the patient.
I must say I fully agree. I fully agree. I don't do routine bone marrow in practice, and occasionally you do see a patient referred to you who's had a post-treatment bone marrow and still has some detectable disease, and they want to know what to do, or that it's already been acted on, for example. And that is a slippery slope, I must say. I always teach the fellows, if you're going to do a test, ask yourself what you're going to do with that information. And right now, I must say, I would not act on detectable minimal residual disease if a bone marrow was done.
I agree. I mean, again, outside the setting of a clinical trial, I don't think there's any need to do a repeat bone marrow, except, for example, if you have a patient who is 6 months out and still has significant cytopenias, and
Yes, agree.
that's the sort of situation that I would do a bone marrow. And also in terms of MRD, again, Dr. Saban has a paper that he looked at some patients like 17 years out, and they still had some hairy cells in their bone marrow, and they were not having any problems. So again, this debate is a huge debate, and it's not something that can be settled in a very short period of time.
I agree. I mean, I quote that paper a lot, Dr. Saban's, the long-term follow, which is quite interesting when you actually do a bone marrow biopsy in patients with completely normal blood counts. And then in a serial bone marrow biopsy, you actually detect them and with really no clinical consequence in need of a therapy. But, when they do, it does upset the patients and raise a whole sorts of questions from their perspective, understandably, kind of what does that mean, what you do with that information. And then I think some of them, I think that's another importance of having a good kind of expert opinions and group giving the thoughts, because some may get another therapy unnecessarily they don't need for many years or whatever. So I think that's kind of the important point to bring out and encourage, obviously, to discuss with their physicians and or second opinions if that ever comes up.